Promoting a community of care in an acute setting will be slightly different from, say, an aged care setting, and the difference is the length of time that people are actually in those settings. So if we think about the aged care setting first. When a person comes into an aged care facility, there's usually an understanding that they will be there for some time. There's also an understanding that they're in that facility to be cared for. So there's already implicitly a sense of a community of care. There will be a nurse, there will be patient care assistants or resident assistants, there'll be other members of the caring community. It's important that people going into an aged care facility understand that that is the context. They're moving into a community of care. Other people need to know what their preferences are so that they can be in a position to inform the medical staff if and when the time comes. In an acute care setting, often enough the admission is quite brief. We know, for example, that overnight admissions in hospitals generally are rising very slowly, whereas the day of surgery admissions are going through the roof. So the model of acute care is changing in this country. The short-term admission does create a problem around the question of community of care, and it's a time problem. Who knows that I've been admitted? Who will be there? Who can be gathered, say from my family or friends, to be part of the decision-making community? The doctors, the clinicians, the nursing staff, the administration staff, the pastoral care staff of the hospital, they're all very time constrained. My admission may be quite urgent, but in any case there are other urgent cases that they're also dealing with. There I think there's an obligation on the hospital community, the administration, the executive, the management, to try and develop a sense of medical treatment within the acute setting still as a community of care arrangement. We can do this in different ways. One is by tapping into the expertise that clinicians have and encouraging clinicians to see that their contribution is about providing the decision maker, whoever that will be, with the best possible information to make the best possible decision. There's no sense, say with an advanced care plan, that the doctor is sidelined. The doctor's role is critical in making decisions, even when a patient has an advanced care plan, because the doctor has the knowledge and the experience. They've been in this position before, they know how these things tend to play out, and they also have the capacity to deal with unforeseen emergencies. So the contribution of the medical staff, the clinicians, is still critical. But I think we need to increase a sense that it's not about making a decision for the patient, it's about contributing information to the decision maker, doing it in a timely way, doing it in a complete way, so that the decision maker can make a decision within the time constraints of the admission, and then care can be delivered. An important thing to understand about the notion of a community of care is that we're not talking about changing the roles that people play in that community. So we're not talking about the doctors changing their role or having a different set of responsibilities. What we're talking about is understanding better the dynamic of the decision-making process. That it's only when a person has sufficient information from all of the sources of knowledge that they need that we can make a truly informed decision and give valid consent to either accept or refuse a path of treatment. So it's very important, particularly for clinicians, to understand. We're not talking about a change of role. We're talking about a slightly different emphasis on the decision-making process. So each member of the community of care needs to contribute from their expertise to the person who is charged with making the decision, so that the best decision can be made in the best interests of the patient. Now, The Code of Ethical Standards for Catholic Health and Aged Care Services in Australia, the CHA Code of Ethical Standards, in the first part of the underlying principles, Principle 5 talks about a community of care, and so there's a good reflection there on what this community of care means in the context of Catholic healthcare. The most important thing of all, though, is to appreciate that a community of care works best when communication is extremely good. So it's important that the decision maker listens to everyone in the community of care. And if it's me, I'll certainly want to hear everyone out. If it's my enduring guardian, I would want that person to listen to all of the sources of information that are gathered around me. We need to be guided by our own experience. My enduring guardian needs to be guided by their wisdom and by my preferences, and make the best decision they can at the time. Trust is one of the most important elements in a community of care. I need to trust. Trust the information I'm getting, trust the people who are providing the information, and then trust my own judgment or my enduring guardian's judgment about the best decision that can be made. Now, it's within that context of communication and trust that an advanced care plan is an extremely important step in the case where I may become non-competent.